Support for this podcast comes from Eyetube.net. Eyetube is ophthalmology's leading source for high-quality ophthalmic surgical videos, educational series, spotlights, and more. Visit Eyetube.net or follow us on Instagram at EyetubeNet.
You're listening to
CRST,
the podcast
from Bryn Mawr Communications.
Welcome to a special edition of CRST the podcast. Today's episode was recorded on site at ESCRS 2025 in Copenhagen, presented by Eytube's meeting coverage. In these segments, leading surgeons offer brief reflections on what stood out to them at this year's meeting, including a surge of presbyopia-correcting IOLs, sustainability and representation, premium lens selection tools, toric optimization, and advances in tissue addition. First up, what's new and what's next in presbyopia-correcting IOLs.
Hi everybody, I'm Suphi Taneri from Münster, Germany. I also work in Bochum together with Professor Burkhard Dick at the University Clinic, and I'm here in Copenhagen at the ESCRS annual meeting, and I'm super excited about the size of the meeting. It seems all the colleagues in all of the world have recognized that this content is outstanding and really worthwhile, and that's why the rooms are jam-packed. And my personal takeaway is that we have a lot of new presbyopia-correcting IOLs coming on the market right now with different technologies, and even more in the pipeline that are expected to be launched in the next couple of years. As I said, all based on different optical principles, and I'm keen to try all of them out. My personal highlight, though, is something completely different. Burcu Yücekul, a young doctor from Turkey who was staying with us, won the ESCRS poster prize, and that made me extremely proud. So if you could not attend this meeting, please come to the winter meeting in Helsinki.
Now, sustainability in practice and the impact of unconscious gender bias on care.
Hi everyone, this is Dr. Radhika Rampat from London, UK. I am so excited to be here for CRST, talking to you all about what I have experienced so far and some of my thoughts on the session so far. And of course, we can't ignore the elephant in the room, or the award in the room, as we call it. I just came out of the Sustainability Arena session where we had a debate with the DOLs versus KOLs, which was with Kathy McCabe, Susan Jacob, David Lockington, Basak Bostanci, and Ben LaHood, and led by Johnson Neo. And it was just an incredible session. We had a great crowd, and the dolls did walk away, or the digital opinion leaders did walk away with the award. But really, the important focus of that was that we got to talk about sustainability and how it's relevant within ophthalmology in this era. Another incredible session that I was part of is the unconscious gender bias session, which is talking about the importance of having women at the forefront of ophthalmology, on the podiums, doing the research, and, preventing manels, as I call them, or all-male panels. Why? Because actually it's very relevant to vision care, because the more representation there is of females within leadership in ophthalmology, and also promoting female patients being confident enough to come and see us and get their cataracts treated, because 2/3 of the blind in the world are women. Why is there this discrepancy? And so we delved into that, and I think it was a really successful course.
Next, making sense of the premium IOL jungle and classifications and decision support.
I'm Dr. Gilles Lesieur from France, and I am speaking from Copenhagen at ESCRS convention, and I would like to, with Paul Dupeyre from Center Redis, optometrist in Center Redis, to speak about new evolution in this Congress. Paul, if you have
Hello everybody, I'm Paul Dupeyre and I'm the co-founder of IOLMatch application, and IOLMatch application is a new application to select the good IOL from the needing of the patient. So we are glad to be there to speak about that.
And the most important thing now is the jungle of all this EDOF and multifocal IOL and premium lenses. And there is a lot of difficulty for the surgeon to go forward in this direction for implantation. In France, there is only 6% of EDOF and multifocal IOL implanted, and 11% of toric lenses implanted. So we would like to improve this premium lenses implantation, and the first of all in this ESCRS convention is the discussion between the classification with ESCRS classification and FRCOphth classification. Paul, do you have
I think it will be better to have clear insights to make the good decision for the patient, because that's the concern of every surgeon. So let's go for that.
And the most important thing is the outcome, and how we can choose the good IOL for the habits and the visual habits of the patient. So with IOLMatch, it could be a good solution, and in the future, perhaps to have an identity card for each IOL mixed with each classification, and to have some level of green, orange or red advertisement to pupil dilation, MTF, and all this to have a good information to the patient and to have a good outcome at the end of the surgery.
Up next, optimizing outcomes with toric lenses.
Hi, I'm Dr. Ben LaHood from Adelaide, Australia. I'm a cataract and refractive surgery, and I've been here at Copenhagen for ESCRS 2025. So thinking about highlights from the meeting so far, I attended a great course on toric lenses that I was part of the faculty for. This is a course that's been running now for over 8 years, and it's well attended. It really is just trying to encourage people to use more toric lenses to try and treat astigmatism properly. And as anyone knows, astigmatism treatment is a big passion of mine. So I think some of the key takeaway messages were, don't be too stressed, because actual complications where you need to do something about the toric lens are extremely rare. And if you do have to manage it, usually the option's actually quite simple. So usually that's either rotating the lens, rarely exchanging it, or thinking about some kind of laser or secondary lens option. That's probably the most important part, is just use toric lenses freely, and they're very easy to work with, and the risk of having a complication is low. But I think some of the other questions and answers that came out of the course were, should you flip the axis, and should you maximally treat any astigmatism that's there, which is true, it's something we've published about. So flipping the axis, absolutely fine. Do you need corneal tomography to be able to put toric lenses in? Not necessarily. I use an optical biometer, I use the IOL Master 700. I'm very happy with that, results are good. I generally only use corneal topography or tomography if someone's had previous laser treatment to look at their corneal shape, or to set expectations if someone has an irregular cornea. One of the other questions that commonly comes up is, how do you look at calculating toric lenses for keratoconus? And there are some new formulas out there. The Barrett and Kane have a keratoconus feature, which has had some good evidence to show that they give a better toric outcome for these patients. So I'd advise using that. But of course, the proviso of that is, if someone's going to continue to wear a RGP contact lens, you don't want to implant a toric lens, or your optometrist will hate you. So definitely for those cases, the important question is for the patient, are you going to continue to wear a contact lens after cataract surgery? So there are some of the great tips, I think, from the toric course, and that's been a highlight so far of ESCRS.
To close, an update on tissue addition with Dr. Aylin Kiliç.
Today, tissue addition is a big innovation for corneal surgery, and I believe this is the future of refractive surgery. Years ago, it was performed by Barracuer. Results were safe, it is clear, but precision was not very good. This is the reason there was a big gap. We didn't use tissue for refractive surgery, but today we are using, because tissue can be shaped with excimer laser, and we can implant human tissue under the flap to correct refraction, presbyopia, or for keratoconus patients, we can create channel, and when we can implant segments, human tissue segments, to correct astigmatism and myopia. This is very exciting. This tissue can be sterilized. Tissue sterilization is very important point. Because of this E-beam sterilization, corneal tissue can be packaged and 2 years shelf life. And when we use this tissue ready to open in operation room, and we can implant into the eye. Today we can correct presbyopia, hyperopia, maybe keratoconus, but in the future we will able to correct, I believe, astigmatism, myopia, and more. So human collagen is very safe. When we recommend patients human collagen implantation, as a surgeon, we are feeling very comfortable. And when we talk with patients, this is a collagen, this is something organic, biologic, patients feeling very comfortable. Because of this, we are performing surgery by communicating patients, and we know both sides very comfortable because it is reversible. It is not like intraocular lens implantation. This is not invasive. With topical anesthesia, we can perform within minutes, and patients is going home back.
For more shows like the one you just listened to, check out the podcast channel on Eyetube.net.